Welcome back to this next video in which we are discussing COPD. Okay, so in this next video what we're going to discuss is the treatment for COPD. So to begin with, I want to talk about the only treatment for COPD that can actually stop the disease progression, and this is by stopping inhaling the noxious gas that is causing the disease in the first place. And this absolutely is the only treatment currently available that can actually stop the disease process from occurring by getting rid of the noxious gas that is causing the whole thing in the first place. So number one on the list of treatments then for COPD is to stop exposure. This is the only way you can stop the disease getting worse, stop the damage to the lungs getting any worse by stopping exposure, and often this means stopping smoking, because normally this noxious gas that you're inhaling chronically and which has caused the COPD is cigarette smoke. So giving up smoking is not an easy thing. Nicotine is an extremely addictive drug, so it requires a lot of support to prevent people relapsing. Okay, right. So that, though, is, as I say, the only way of stopping the actual disease process. All of the other treatments that I'm going to give are just symptomatic treatments. They're going to treat the symptoms of COPD. They are not going to stop the disease process of COPD. Okay, so onwards now to discuss symptomatic treatments of COPD. So the number two category of treatments for COPD are the bronchodilators. And these are going to be used to treat the breathlessness of COPD. So the major symptom of COPD is the breathlessness. This is the symptom that's really quite scary. If it gets very severe, you do feel as though you are drowning. So it's a very, very scary symptom. And bronchodilators are going to help to control that symptom of COPD. So as the name suggests, these are going to be drugs that are going to dilate the bronchi and the bronchioles. Okay, bronchodilators. So, in order to understand the pharmacology of these drugs, what we're going to need to do is we're going to need to study in a little bit more detail what controls the contractile status of the bronchial smooth muscle cells. So I've talked about the fact that around the bronchi and the bronchioles you have these bronchial smooth muscle cells, and that when these contract, what it's going to do is it's going to decrease the circumference of the rings of bronchial smooth muscle cells and therefore narrow the lumen of the airway, which is bronchoconstriction. Alternatively, if they were all to relax, you'd get the opposite thing happening, you'd get bronchodilation. So the question now becomes, what actually controls how contracted these bronchial smooth muscle cells are in the bronchi and the bronchioles? Because there is control over that, and we need to now study that, because the drugs that we're going to use are going to manipulate that control system. Oh, and of course, if we were to dilate the bronchi and the bronchioles, then this will hopefully help to reverse some of the obstruction to airflow that occurs in COPD. Remember, because of the fibrosis in the lamina propria, which narrows the airways, and that's one of the key things that leads to the tidal volume being reduced and therefore the breathlessness. So by dilating the major airways, hopefully we can reduce the breathlessness. Okay, so let's go back over here and now discuss the control then of the contractile status of these bronchial smooth muscle cells. So let me just draw here a bronchial smooth muscle cell in the classical spindle shape. So this is our smooth muscle cell. So what does control how contracted bronchial smooth muscle cells are? So the answer is it's under the control of the autonomic nervous system. The two divisions of the autonomic nervous system both innervate bronchial smooth muscle cells, and therefore your autonomic status, i.e. whether you're in the fight or flight response or the rest or digest response, controls bronchial smooth muscle cell contraction. So let me just explain this in a little bit more detail. So controlling smooth muscle cell contractile status then are the sympathetic nervous system, SNS, so I'll just put the fact that this is the sympathetic, and then NS is just nervous system. And then on the other side, there is the parasympathetic nervous system. So this is the PNS, so the P stands for parasympathetic nervous system. Now these are kind of complete opposite nervous systems. They are involuntary nervous systems, and they are structures or systems that become activated differentially depending on what the current status is. of stress. So, if you are in a very stressful situation, a life or death situation, which we might call the fight or flight situation, so let's say you've just seen a bear that is going to try and eat you, then either you're going to fight the bear or you're going to run. This is the fight or flight situation. This activates the sympathetic nervous system and reduces down the parasympathetic nervous system. So in response to the fight or flight situation, sympathetic nervous system goes up, the parasympathetic nervous system is toned down. Okay? Whereas, in contrast, in a relaxed situation, so let's say we're in a relaxed situation, and this is often called the rest and digest situation. So you're going to rest and you're going to digest the food that you've eaten recently. So the rest and digest situation, this inactivates the sympathetic nervous system. So the sympathetic nervous system activation goes down and it activates the parasympathetic nervous system. So this nervous system becomes activated in stressful situations, and it's going to lead to lots of changes around the body that are appropriate for the current situation. They're going to help you deal with fighting or flying or, running away. Whereas this nervous system, it's activated in response to rest and digest situations, and it's going to activate an appropriate changes around the body for resting and digesting. So they're completely antagonistic, really. There are examples where they're not completely antagonistic, but we'll steer clear of those. As far as their effect on the bronchial smooth muscle cells is concerned, they are completely antagonistic. So, the sympathetic nervous system innervates bronchial smooth muscle cells. So in the bronchial smooth muscle cell layer of the airway walls, you will have sympathetic nerves and parasympathetic nerves innervating the bronchial smooth muscle cells. So sympathetic nerves, they release the neurotransmitter noradrenaline, which for short I'll abbreviate to NA, and in the States this is called norepinephrine, so noradrenaline, which is going to act on receptors on the surface of the smooth muscle cells called the beta-2 adrenergic receptor, which is a G protein coupled receptor, so it has this classic structure of 7 membrane spanning alpha helices. So this is the beta-2 adrenergic receptor is what AR stands for. So noradrenaline can bind to this receptor, activate it, and what it triggers is an intracellular signaling cascade that leads to the bronchial smooth muscle cell relaxing. And therefore, if the bronchial smooth muscle cell relaxes, that means that you're going to get the increase in the circumference of the bronchial smooth muscle cell rings, and therefore you're going to get bronchodilation. So bronchodilation will occur. Now, why would you want that to occur in response to the fight or flight situation? Well, the reason is that if you get bronchodilation, you can now bring in more air more easily into the lungs. And that's exactly what you need to do, because you are preparing to run or fight, both of which will require a lot of skeletal muscle cell activity. Those skeletal muscle cells are going to use oxygen. So your oxygen demand on the body is going to increase, basically. You know this. If you jog, you need more oxygen. Okay? So this is the reason we would want the airways to dilate so that we can get more air into the alveoli, into the lungs, more easily. Okay, so that's the reason that you want bronchodilation in response to a fight or flight situation. Now let's do what the parasympathetic nervous system does. So the parasympathetic nervous system, you have again parasympathetic nerves in the bronchial smooth muscle cell layer, which will be innervating the bronchial smooth muscle cells. They will be releasing the neurotransmitter acetylcholine, which for short I'll abbreviate to ACH, like so. So this is acetylcholine. And this will be acting on the M3 muscarinic acetylcholine receptor, which is again a G protein coupled receptor. So this is the M3 receptor. And if you want, you can put muscarinic acetylcholine receptor here. M for muscarinic, which is a class of acetylcholine receptors that responds to the chemical muscarine. So this is specifically the M3 muscarinic acetylcholine receptor. So these parasympathetic nerves, when they're activated, they release acetylcholine, activate this receptor. This receptor activates an intracellular signaling cascade that leads to the exact opposite. It leads to contraction of the bronchial smooth muscle cells, and therefore when you activate the parasympathetic nervous system, you get bronchoconstriction. So in response to a relaxed situation, you want to constrict the bronchi. Now, why would you want to do this? Why wouldn't you just permanently want them dilated? Well, to understand this, let's go back to my little drawing of the ventilatory cycle. So you have to remember that when you breathe, so when the diaphragm comes down and pours air into the lungs, not all of that air, not all of that fresh air, that tidal volume's worth of air, is actually going to go into alveoli. A big volume of it actually is just going to end up in the large airways, so in the trachea, the bronchi, and the bronchioles, because you have to remember when you pull it in, it comes in this way. So, these are the places that are first going to be filled, and as air goes into the alveoli, you're still going to have fresh air in these airways. So some of the volume of the tidal volume is actually just going to be sitting in the airways when you've inhaled, or inspired rather. So not all of the tidal volume actually does end up in the alveoli, and that volume that doesn't actually get into the alveoli, that's known as the anatomic dead volume. So this is the unavoidable volume that's not actually going to be of any use because of anatomic reasons, so the anatomic dead volume. Now, if your airways are really wide, then that anatomic dead volume is going to be increased, and therefore you're not actually going to get as much air into the alveoli where it can take part in gas exchange. This is the reason that whilst in a relaxed situation, you want the airways to be more constricted than they would be in a stressful situation, so that you can reduce the anatomic dead volume. When you're in a stressful situation and you need a huge amount of oxygen, and you're going to be using the accessory muscles of ventilation, there it makes more sense to dilate the airways. Yes, the anatomic dead volume will go up, but the improvement as far as the fluid dynamics, i.e. the reduction in resistance to airflow that you get by increasing the diameter of the airways, is better in that situation. In the relaxed situation, it's better to have them constricted than have the anatomic dead volume reduced. Okay, right. So this is the way then that the contractile status of the bronchial smooth muscle cells is controlled by the sympathetic and parasympathetic nervous system. So in a fight or flight response, this one goes up, this one goes down, you bronchodilate. In a relaxed situation, this one goes up, this one goes down, and you bronchoconstrict. So normally there is a balance between these two forms of stimulation, one that is telling the smooth muscle cells to relax, and one that is telling the smooth muscle cells to contract. And the bronchodilators are going to manipulate this system. So we are going to get the bronchial smooth muscle cells to relax in two ways. One, by activating these receptors, and alternatively by blocking these receptors. And of course we want to do this in COPD so that we can open up the airways and reduce the breathlessness. Okay, so let's now talk about examples of bronchodilator medications then. So all of these medications are going to be given by the inhaled routes. They're going to be given through inhalers. So people with asthma are not the only people who use inhalers. People with COPD often use inhalers as well. So in mild breathlessness then, the bronchodilators that are used are what are called short-acting beta-2 agonists. And for short, these are abbreviated down to the SABAs. So this stands for short-acting SA, and then the B is for beta-2, and then the final A is for agonists. So these are going to be drugs that are going to bind to the beta-2 adrenergic receptor and activate it, and therefore cause relaxation of the bronchial smooth muscle cells, and therefore cause bronchodilation. So that's exactly how they're going to work. So let me give you some examples then. So the two absolutely major ones are salbutamol and terbutaline. So salbutamol, a very famous drug, and also terbutaline, not quite as famous, but also a very important drug. So terbutaline. So those are the two major short-acting beta-2 agonists. And let me just explain what is meant by short-acting. This means that they only act for a few hours. What we'll see is there are also long-acting beta-2 agonists which work for a much longer period of time. They're slightly stronger drugs and will produce bronchodilation for a longer period of time than the shorter-acting beta-2 agonists. So the longer-acting ones will be given in more severe cases of breathlessness due to COPD. In addition, in mild breathlessness, you can also give a drug in the class of anticholinergics. So these are drugs that block the acetylcholine receptors, and specifically it's going to block the M3 muscarinic acetylcholine receptor. In fact, the two drugs that are anticholinergics that we're going to discuss actually block all of the muscarinic acetylcholine receptors, but for their function as bronchodilators, it's the M3 receptor that's specifically important. So, in mild breathlessness, the anticholinergic that can be used is ipratropium bromide. So I'll put this here. Ipratropium bromide. So this is a competitive antagonist of the muscarinic acetylcholine receptors, and it will block the M3 muscarinic acetylcholine receptor. So what will happen is, here's the M3 muscarinic acetylcholine receptor. This drug can bind to that receptor just like acetylcholine can, but it will not stimulate the receptor. It will bind in the spot where acetylcholine would bind, blocking acetylcholine from binding, but it does not activate the same intracellular signaling pathway as acetylcholine would when it binds to this receptor. So it binds to it, blocks acetylcholine from binding, and does not stimulate contraction. Therefore, it cuts off this stimulation of the bronchial smooth muscle cells. It stops the parasympathetic nervous system being able to tell the bronchial smooth muscle cells to contract, and therefore will cause overall relaxation of the bronchial smooth muscle cells. So you have to understand that usually when you're in the relaxed state, the parasympathetic nervous system is all the time telling these bronchial smooth muscle cells to contract a little bit to keep the airways at a narrow diameter. So we're going to block that instruction, and therefore the airways will now not receive that instruction and will bronchodilate, therefore. So that's ipratropium bromide, an example of an anticholinergic or a muscarinic antagonist, which is used in the treatment of mild breathlessness. So that was the treatments, the bronchodilators used in mild breathlessness. Now let's go on to the bronchodilators used in moderate to severe breathlessness. So they're the same categories of drugs. We're again going to have beta-2 agonists and anticholinergics. Now what we're going to have, however, is the long-acting beta-2 agonists, so LABA now. So hopefully you can understand exactly what that means. Just replace the short with long now. So these are going to do the exact same thing. They're beta-2 agonists. They will bind to the beta-2 receptor, and just like noradrenaline, they'll activate the signaling pathway, but they act for a longer time. So once you've inhaled them, you've taken the medication, it will act to produce bronchodilation for a longer period of time than the short-acting beta-2 agonists would. So examples then are salmeterol, formoterol, and indacaterol. So salmeterol is an example. Formoterol is also a very important example. Formoterol. And another example is indacaterol. Indacaterol. Okay, so those are all long-acting beta-2 agonists, and we understand their mechanism by which they will help to bronchodilate and therefore improve the breathlessness. In addition, in moderate to severe breathlessness, there is another anticholinergic, another non-selective muscarinic antagonist which will block the M3 muscarinic acetylcholine receptor. So another anticholinergic, and this has a very similar name. It's tiotropium bromide. And again, I'll remind you, this is a non-selective antagonist of the muscarinic acetylcholine receptors, so it will block the M3 muscarinic acetylcholine receptor. It would block M1, M2, M4, and M5 as well, but M3 is the only one that we're interested in here because it's the one on the bronchial smooth muscle cells. So I'll block that receptor by binding to it, not activating the signaling pathway, blocking acetylcholine from binding to it, and therefore, even though the parasympathetic nervous system is screaming at the bronchial smooth muscle cells to contract by spraying acetylcholine at them, they just can't hear the acetylcholine because their receptors are neutralized by the drug. Okay, and therefore you get more dilated airways than you would have if the instruction from the parasympathetic nervous system was getting through. Okay, right, so those are the bronchodilators. They're symptomatic treatments for breathlessness, so they help treat breathlessness. And some people will just use them when they're feeling breathless, particularly people with mild breathlessness who are using the short-acting beta-2 agonist. They might just take the drug when they're actually feeling breathless. So if they've gone on a walk maybe into town and they're feeling breathless, they might take their inhaler, have a puff, and that will open their airways somewhat. And they do act very quickly. That's the good thing about these. They act very, very fast to dilate the airways, and that will help to ease away the breathlessness. As the breathlessness becomes more severe, then these long-acting beta-2 agonists might just be taken prophylactically on a regular basis. So they'll take them a few times a day at regular intervals just to try and prevent episodes of severe breathlessness from occurring. Okay, right. Now, the next thing I want to talk about is the fact that inhaled corticosteroids and oral corticosteroids are actually not effective at all at preventing the disease process, and it's not really understood why this is. So I'm just going to put this up here because this isn't really treatment for COPD. This is treatments that don't actually work for COPD. So people expected, when they began to understand the pathogenesis of COPD, that it involved this chronic inflammatory response involving these neutrophils and macrophages, that oral corticosteroids or inhaled corticosteroids, so ICS means inhaled corticosteroids, so drugs like beclometasone, fluticasone, mometasone, ciclesonide, budesonide, used in asthma. They thought these inhaled corticosteroids might be useful in the treatment of COPD because they would hopefully cut down this chronic inflammation and hopefully reduce the progression of the emphysema and the progression of the chronic bronchitis. However, they are not effective, and it's not really understood exactly why they are not effective. There are theories as to why they're not effective at halting the progression of COPD, but it's still not completely agreed upon. So unless you actually stop your exposure to the noxious gas that is actually causing the COPD in the first place, just cutting down the immune response with inhaled corticosteroids is not going to actually prevent the progression. And oral corticosteroids aren't effective either. So oral corticosteroids would just be used in the treatment of acute exacerbations of COPD to curve down the inflammatory response there in response to the chest infection and reduce the acute exacerbation symptoms, but they're not used to try and halt the disease progression because they simply don't work, even though you might expect them to work because of the fact that we've seen that COPD is this chronic inflammatory process that leads to the emphysema and the chronic bronchitis. Okay, right, so those don't work. Finally, what I'd like to talk about with regards to the treatment of COPD then is pulmonary rehabilitation therapy. So number 3 here is what's called pulmonary rehabilitation. So this is effectively a training program involving exercise mainly, and also lessons on how to breathe more effectively. So pulmonary rehabilitation. Okay, so as I say, the major thing this involves is exercise program. So people with COPD can be put on this pulmonary rehabilitation program, and they'll go to these exercise classes. They'll be taught how to do exercise in their own time, certain exercises that will make them breathless initially, but over time hugely reduces their breathlessness. So this does work to treat the symptoms of COPD. Now, how then does this pulmonary rehabilitation therapy work? Well, it does not change the lung disease. It does not repair the lungs. Instead, what it does is it makes the body function more efficiently with the low level of oxygen and the high level of carbon dioxide that will most likely result because of the reduced lung function. So it helps the body to adapt to the new levels of oxygen in the bloodstream because of the COPD, and therefore reduces the sensation of breathlessness even though it hasn't actually improved lung function. So it does improve quality of life hugely, so it does make you feel less breathless, and so shortness of breath does go down, but that's not because lung function has improved, that's because the body's ability to cope with the reduced lung function has improved from the exercise program, and this is extremely effective at improving quality of life. The biggest problem with pulmonary rehabilitation is getting people to actually comply with the treatment. So it's often the case that they will go to the sessions and do the exercise actually in the sessions, but then they will stop very quickly doing it at home once the sessions are over, which means that it's then not as effective. Okay, right, but that is a important treatment to put there for the symptoms of COPD, reducing the breathlessness associated with COPD. Okay, right. So that concludes my discussion of the treatment of COPD, and in fact that concludes my discussion of COPD overall. I hope that you have enjoyed the video and I hope that you've learned a lot from it.